Welcome again to MLS QR Medical Lab Science Quick Review for Infectious Mono. We'll look at microscopy, lab tests, Epstein-Barr virus serology, and then we'll have a question and answer based on the ASCP Board of Certification exam. And it all began with a kiss. Active Epstein-Barr virus spreads person to person, mainly by saliva. Thus, it is known as the kissing disease. But it can also be spread by sharing utensils and other body fluids like blood and semen. After several weeks of incubation, symptoms appear. Fatigue, malaise, headache, fever, sore throat, swollen lymph nodes around the neck, a rash. The oropharynx and the tonsils may appear inflamed, reddish hue with yellowish white lesions. We'll focus on a few specific lab tests that will help with the diagnosis of Epstein-Barr virus among the many other respiratory infectious microorganisms that should be considered by the clinician. EBV is a member of the herpes virus family and is known to cause the classic clinical syndrome infectious mononucleosis, which may be caused by other viruses as well. EBV is the first known oncogenic virus discovered in 1958, described in Burkitt's lymphoma, an aggressive cancer of the lymphatic B-cell germinal centers. Epstein virus can infect immunocompromised hosts, cause other lymphoproliferative disorders, and it's known to be linked to autoimmune disease and long COVID. To understand the Epstein-Barr virus serology and antibodies, it is good to know the antigens of the Epstein-Barr virus. A viral envelope protects the virion. Viral glycoproteins are embedded in the viral envelope. The icosahedral capsid, made of capsomer proteins, encapsulates the double-stranded linear genome, which encodes for about 80 viral proteins and multiple non-coding RNAs. A protein viral tegument covers the capsid like a viral skin, analogous to our integumentary system, our skin. Epstein-Barr virus serology involves the study of serum and other body fluids, usually in terms of diagnostic identification of EBV antibodies in the serum that form from the adaptive immune response from the foreign EBV antigens. We'll look at two types of antibodies, IgM pentamer and the IgG antibody. But first, the CBC. What can you tell me about the white blood cells in this CBC report? Let's just ignore the red blood cells for now. Leukocytosis, lymphocytosis, absolute and relative lymphocytosis. This is consistent with a viral illness. If you noted absolute monocytosis, you're correct as well. Lymphocytosis is the process of making a lot of lymphs, and relative lymphocytosis is simply the differential lymph count is above 42%, the normal reference range in ACP study guide. The absolute count is easily calculated taking the total white count multiplied by the relative count in the differential. Units of measurement are shown below in different variations. This is a form of concentration of count per cubic millimeter or volume, and it's also expressed as thousands per millimeter cube or thousands per microliter or thousands per lambda. And bear in mind that a drop of liquid has approximately 50 lambda, and this is a very tiny volume. So we're looking at thousands of lymphocytes in this tiny volume of lambda. CBC flags, like those we've seen, will prompt us to perform a peripheral blood smear exam. An atypical lymph is the hallmark of the CBC peripheral blood smear for a patient with infectious mono. This illustration demonstrates large mononuclear cells with large purple basophilic nuclei surrounded with abundant light blue cytoplasm with scalloping around surrounding red blood cells. Bear in mind that this is not diagnostic since other viral and bacterial infections may present with atypical lymphs. These cells represent CD8 positive T lymphs that our immune system responds to the infection. They are activated and react by attacking the infected target cells. Hence, they are also known as cytotoxic T lymphs. Atypical lymphs are slightly different from reactive lymphs and variant lymphs and are sometimes confused with monocytes in the manual diff. One rapid and efficient test to order with the CBC is the mono test, a test for heterophile antibodies. A heterophile antibody is an antibody that reacts to different antigens in different species. And a few notes about heterophile antibodies and the test kits. Heterophile antibodies induced by external antigen with some cross reactivity with other antigens, both self and non self antigens. EBV causes heterophile antibodies of the IgM type that cross-react with sheep and horse red blood cells. In fact, historically, we had the Paul Bonnell test and the Davidson differential with guinea pig kidney and using sheep red blood cells. And this was used for a test for infectious mono and heterophile antibodies. These test kits has fairly low specificity because false positives occur with non-EBV infections such as HIV, lymphoma, systemic lupus erythematosus, and immunodeficiencies, other diseases. These test kits have fairly low sensitivity because they are insensitive with false negatives seen in patients with actual EBV infection, and they are confirmed by the other tests. An interesting question in the ASCP study guide asks about heterophile antibodies and test kits. Which disease is likely the cause for a patient with atypical lymphs in the peripheral blood smear but has persistently negative monospot heterophile antibody test results? Cytomegalovirus infection is the most common cause of heterophile negative reactive lymphocytosis. There are more specific and sensitive serological tests, so we'll look at these. But before we do, we will be looking at IgM antibodies and IgG antibodies that are secreted by the B lymphs. Activated B lymphs secrete first IgM antibodies, later IgG antibodies. These B lymphs mature to plasma cells, and you see with their characteristic perinuclear halo, they represent Golgi apparatus and their ribosomes also actively making these antibodies. And as you already know, the T lymphs are the CD8 positive T cells that are cytotoxic lymphs. IgM is a big pentamer molecule. It is an antibody that appears in the acute phase, and later on, the IgG appears during the convalescent phase. EBV serology includes anti-BCA IgM and IgG type, which is the antibodies against the viral capsid, and then antibody against the early antigen, and antibody against the EBV nuclear antigen. This EBV serological profile shows you that on the y-axis there's antibody titers versus the x-axis, which is time in weeks and months. And after the incubation phase, there's an acute phase, a convalescent phase, and then a recovery phase. Since EBV is difficult to culture, the clinician relies upon the classic serological diagnosis of at least a fourfold rise in titer 4 weeks apart from onset of symptoms to compare acute and convalescent titers. IgM is expressed early on, VCA IgM, and then it declines rapidly. PCA IgG rises during the acute phase and stays elevated during the convalescent and recovery phase and for life. And this shows past infection. But according to the CDC, this general pattern of IgM, IgG, and acute and convalescent titers may not always be useful. According to the Centers of Disease Control, EBV nuclear antigen and antibody appear later after acute infection and persist in the blood during life as EBV remains latent in infected B cells. Enzyme linked immunoassay, or ELISA, provides more specific and sensitive diagnostic information for the Epstein virus diagnosis. Direct lysa methodology employs a enzyme link conjugate with antibodies attaching to the antigen on the plate, and then you'll have substrate converting to the product, which is measured. And the indirect method, you have a two-phase part where you have the antibody conjugate, then you have the anti-human antibody conjugate with the enzyme linked to that, where it will convert the substrate to a product. Immunofluorescence is another powerful specific test for Epstein-Barr virus, where you have a direct and indirect methodology, just like you see in ELISA. Instead of an enzyme link conjugate, you have a fluorophore link conjugate next, and this will attach to the antigen in the tissue infected with the Epstein-Barr virus or B cell suspensions. And the indirect method has a secondary antibody, which is anti-human antibody conjugated to the fluorophore, and that will attach to the primary antibody, which will be attached to the antigen in the tissue or the B cell suspension. And then the fluorescence will be measured, and that is a very powerful method, and we will see how it looks like. Time for some Q&A with the ASCP Board of Certification type questions that are similar but not exact as in the study guide. And let's give it a go.